Well, good afternoon, everybody. This is Harold Pyun. It is Sunday, April 5th. It's Palm Sunday. First and foremost, I hope that all of you that are watching are doing safe and well, and I hope you and your loved ones are all healthy. If you haven't already, please, you can like and subscribe. I'm going to try to post videos here and there that might be able to give you some insight, support, and ideas for those centers that are planning to provide alternative services for your CBAS centers and your CBAS participants. I did post a video last week kind of giving you my take on the most recent ACL letter that was issued by the State Department of Aging. I know that Department of Aging, CDPH, CMS, CADS, are all doing their best to help us to create our support systems, to create the ability and capacity, organizational capacity to provide services to our participants. Excuse me. So first and foremost, thank you for your efforts. Today's video, I wanted to talk about some conceptual ideas related to your efforts as you create alternative services and your plans for operations. Prior to developing any system, forms, processes, policies, I think you have to first of all have a conceptual model, conceptual understanding that can help guide you and inform you in terms of your efforts. So first and foremost, I came up with this little model here, and what we're creating here in terms of the alternative services is really unique to the current circumstances. So as you see on the left, we have the left circle, which really denotes our current ADHC CBAS program model. That's business as usual outside of the context of what's going on in the world today. And then on the right side, you see the circle called CM models. And this really represents what care management models might look like on a normal basis. So as I mentioned in my prior video, this isn't just about making telephone calls. You really need to have an understanding of what it is that you're doing in the context of case management. We might be providing services telephonically or even in the home, and whether those might look like services that were typically provided in your ADHC center, they're not necessarily the same. So again, what I found helpful was understanding on the left side, again, you have what your typical ADHD services would be. On the right side, you have what a care management model would be. And if you haven't really worked in developing care management programs, do some research into it. Because again, it isn't just about making calls. And then really the union of those two models, the case management model and the CBAS model together. This is really what we're looking at, is how can we integrate care management models telephonically face-to-face into the ADHD context. But we're adding a third element here. We're operating in the contextual constraints posed by the COVID-19 threat. Largely, as you'll note on the left, this is a time of transition and this is a time of crisis. So typically, if you have a participant that's discharged or goes to the hospital, skilled nursing is discharged, comes back to CBAS, what do we typically do? You do a reassessment, right? And it is so important to understand that first and foremost, this is a time of transition, because even though your centers are physically where they used to be, the fact is your participants aren't coming out to your centers at this time. So this is a kind of a reverse sense of time of transition because they're stuck at home. So I want to emphasize even the models, the forms, the principles, the processes that I am implementing. Right now working with 4 different centers, is unique to this situation. What I created in terms of care management historically in the past for a program that I helped build for Anthem Blue Cross, even what I'm doing for this situation is unique from then. Because population, first and foremost, was different. But more importantly, we are trying to provide alternative service in the context of the constraints posed by the COVID-19 threat. And I'm going to talk about this time of transition because it is important. Okay, and I'll get back to that in a little bit. So as I mentioned, this model is meant to be temporary, right? First and foremost, ADHCs are given a little bit flexibility in terms of regulations, both in terms of operations, staffing, hours, etc., etc. So what you're doing now is not meant to be permanent. At the same time, case management in the context of what we're doing now for CBAS and the COVID-19 threat, the case management that will be provided here may not necessarily be the same as case management that you might provide under quote-unquote normal times. Okay? And then finally, as I want to reemphasize, due to the COVID-19 threat, we have certain environmental constraints that may not typically be in place if you are trying to provide alternative or case management services otherwise. So a couple things to keep in mind. For me, when we talk about care management, there's really two basic interfaces. There's the telephonic and face-to-face. Now, with the constraints in mind, kind of my general prediction is that maybe 90 to 95% of the services provided in the alternative model through the CBAS centers will mostly be telephonic. And as you saw in the ACL from March 27th, 2020, they list the typical menu of services that can be provided by centers. And largely, they're very generic from at face value. And as I've mentioned earlier, it's about really understanding, well, how are we going to provide those in the context of CBAS, utilizing care management standards of practice and principles under the constraints posed by COVID-19. Then we have face-to-face, keeping in mind safety, prevention measures, not only for the participants that you might be meeting, also for your staff that go out to possibly deliver meals, to possibly provide some face-to-face services, whether it's social services or nursing, medical, or OT, PT. Okay, so these are the two typical, service modalities, service interfaces in care management. And I have this flow chart here because one of the first steps that I believe is most important is kind of knowing what your battle plan is, getting an idea of what you're going to be doing. And one of the core components of that is understanding your population, your participants. Yes, you've been working with your participants. You've done full-on assessments. You've been providing services. You've been documenting services for them. But at this time, many of you may not have, we as ADHC centers may not have had to do a pre-tiering process. And what this means for equivalent to what normal operations would be, it might be related to our TAR days. So TAR 1 day up to 5 days of service, right? But in this context, pre-tiering is very important. So one thing I had with the centers is we sat down and we needed to pre-tier. One document I used was the participant characteristics. It's a great source of data to identify pre-existing risk factors. On top of course, the TAR days and of course your assessments. However, if you recall, we are in a time of transition, a time of crisis. So for me, it is important to understand or identify your highest risk members and make sure you're putting most of your attention towards them. However, quickly, after establishing your kind of triaging, or I call tiering up your population, I have 3 tiers, CM1, CM2, CM3, it's going into doing an assessment. Now, prior to the assessment, I have the staff do a verbal consent. And this isn't, we have our participation agreements. They have those agreements signed. We have all the release forms signed, right? Because you've admitted them under the normal CBAS program. However, this is a new model for them as well. So I think it's out of courtesy or even practicality. I had letters sent out to all the participants introducing them to what we might be doing as a center so they have a heads up. Not only the participants, but also their families. Because you might encounter people that may not want to get calls from you. As I mentioned, they might have been living alone and perhaps they moved in with family. Now you might be calling their family's house. So I think it's just courteous, out of courtesy, to let them know and kind of get their verbal consent. And this isn't a huge process. I do have a form for that, but it's not a huge process. It literally can be inferred through just literally a few minutes of talking with him to start off with. Then after that, we do an assessment. Now, I'm not saying we do a full-on assessment like your initial or reassessments, but doing some sort of assessment at this point in time. As I mentioned, this is a point of transition, a time of transition, a time of crisis. So all the data you have pre-existing from your assessments and your charts, we cannot make assumptions based on what we know. We need to know what we know now because things have changed. And it's already been several weeks, right? So before deciding to provide any services or just, blindly going off your IPCs to say these are the services we're going to provide and, just making phone calls, I think you might be missing some important information if you do not do an assessment. So I have assessment forms created for the staff as well that they use. And I'm asking unique questions that would never be asked on an assessment. And I didn't ask when I had the care management program that I developed in the past. So getting verbal consent and completing assessment is important. Finally, after that, we create a CM action plan, a case management action plan. This is separate from your IPC. As you know, your IPC has interventions, problem statements, goals, and frequencies, and we all know what an IPC looks like, right? But I also create a separate action plan. But of course, it is informed by your IPC. Okay, so I do create a sub-action plan that is linked to, but yet unique from your IPC. And why do I do this? Because what might needed to be provided in the IPC may not necessarily be provided now or may not be able to be provided in this current context, right? In the current context of this crisis and the limitations in the environmental constraints that we're faced with. Secondly, as I talk about the pre-tiering, right? We have TAR days 1 through 5. However, it is important to not make the assumption that your 5-day TAR people, you will be interacting with them 5 days a week. Now, TAR days are a great guide, and one element that I use in pre-tiering our clients, our participants. However, it is important to be open to the fact that your frequency of your CM action plan, the interventions identified in the action plan, may not be the same as the TAR day frequency. So 5-day TAR individuals, participants, you might not be reaching out to them 5 days a week. Vice versa, your 2-day TAR people, you might need to be reaching out to them more than 2 days. Keep that in mind. So don't just think that 2-day TAR people may only now require in this time, in this situation, 2 days of interaction. Now there comes a question to reimbursement. If this is a need, where you have a 2-day TAR person needing 3, 4, 5 days of interaction, okay, we may not get reimbursed for that. However, if we're truly looking at the participant's safety, perhaps we may need to eat that up a little bit, right? We have to take everything in context because I believe we're going to get per diem reimbursement. And we may need to provide certain level of minimum services within the context of the fact that, we've been given some flexibility with how our operations may be. So personally for me, I think that we must provide what is needed, right? Even if it means, you might not get reimbursed for 5 days of service if it's a 2-day TAR person. But remember, we're doing this for the protection and safety of our participants. And then, of course, all the great services that you're providing in the action plan linked to the IPC. Literally on the action plan, I have them link the CM action plans to the IPC intervention numbers, even the participants' needs, goals, and wishes. I literally have them do that on the CM action plan form that we have. And then, of course, we're providing services and we're documenting all of those. And I have separate forms for those as well. Now, the final block talks about completing an assessment. I'm not sure about this. Maybe having it coincide with reassessments or quarterly assessments. I'm not sure, to be honest, because this is completely new. As I mentioned, I've been working with 4 centers and have been able to implement this, and we are already implementing assessments. We're developing action plans. We are providing services. So this video that I'm making today is really speaking from at least some minimal level of pre-implementation and some important ideas that I've gleaned so far from our experience. Some ideas for creating tiers for your participants. In the other care management program that I developed, there were 3 tiers, 1, 2, and 3. CM3 were the neediest people, and the plan would authorize a certain number of billing units that we could utilize, whether telephonically or face-to-face. Now, in the context of CBAS, it's a little different, but nonetheless, I believe it's always good to triage and identify your population. And here are some ideas, if you look at the grid, that could help guide you. Again, I refer to participant characteristics reports and other reports. And in addition to that, their TAR status, how many diagnoses do they have, their social living situation, their their medication management, their psycho-emotional social status, and their dietary meal needs. Okay, so just one note about prescription management. I am very, very concerned about something as simple as, are they going to be able to get access to prescriptions? And in the form, and as I train the staff, I literally ask them to ask, do you have your next order, your next prescription pre-filled and ready to go? And if they say no, well, we know we have something to work on. If they say yes, I literally have them ask, how are you going to get it? Are they going to deliver it to you? Are you going to have a family member pick it up? Are you going to pick it up? Will you pick it up from the center? Same thing with meals. I'm concerned about the ability of some of our participants to even get their basic 2-3 meals a day. This is a big concern. Maybe not for all your participants, but for many. Okay, so again, looking at your social status. Prior, in the past, maybe they lived with family and now they live alone. Or typically, maybe they lived alone and now living with family. Now, we can generally assume that living with family could provide more support, more meals, more access to resources. Generally speaking, yes. But we can't assume that it'll always be positive. We hope it will be. But perhaps our participants haven't been living with their adult children for many, many years. And perhaps there was a strained relationship. So some of their basic needs might get met, but who knows about their emotional, psychosocial status, right? They may be really stressed. It's a transition. It's a change. Not even if, it doesn't necessarily have to be they had a bad relationship, but it is a new living situation. Secondly, with the psycho-emotional status, with those with pre-existing DSM diagnoses. So we had those that have no history. We have those that have history of DSM diagnoses with no active symptoms because it was historical. Then we have those that have DSM diagnoses with active symptoms. 2 groups that I'm concerned about all. Even those with no diagnosis history, I'm sure they're experiencing some type of emotional, psychological stress. Now, the other 2 groups, those who had a historical diagnosis of some DSM diagnoses like depression, even if it was inactive, it might become activated. And those that have a active diagnosis, a DSM diagnosis, and have active symptoms, well, I can only imagine those signs and symptoms probably got exacerbated. So on that note, we have participants that have psychotropic medications and were receiving psychiatric care or counseling from a non-CBAS center affiliated program. And so that comes to one of the other important points, it's the liaison. It's the coordination of care. That's a huge one in care management, care coordination, right? So I make sure that our social workers or nurse are communicating not only with the family, not only with the participants, not only with the doctors, but other possible allied care services that might be involved with the participant. In this case, for example, a psychologist or a psychiatrist that might be prescribing their medications. So just some ideas for you to help establish tiers when you're trying to triage your population. So finally, again, purpose of this video was to give you some ideas, starting with a conceptual model, right? Starting with a conceptual model, because it is important to understand that what we're trying to do and the context that we're trying to provide it in. First and foremost, you're all successful professional ADHC CBAS programs, but not all of you may have had experience in care management or developed care management programs. And here you are trying to create an alternative service segment that integrates both, but in the context of the COVID-19 threat. And then finally, having some general idea of what it is that you're doing. So in the centers that I work with, created forms that help us do verbal consents, do CM case management assessments, create separate CM action plans, and then documenting those services in forms that are related to this alternative service. And again, this program that I've been developing is meant to be unique to this situation, and it is meant to be temporary, because I'll be honest with you, if I were to create a similar program, but let's say we did not have the context or the constraints posed by COVID-19, the program would look a little different. So I do want to reinforce you that this model is meant to be temporary. So with that, I hope that you were able to get maybe some tidbits of information that could inform and assist you as you develop your alternative services for for CBAS centers and for your participants. And if you haven't already, just go ahead, leave a comment below. You can subscribe, and please feel free to share this with any of other centers or individuals that might benefit from this. Again, I'm doing this to help provide support. We're all in this together. And with that, we'll call it a day and end your weekend well. Have a great weekend. Have a great rest of your Sunday. Oh, also tomorrow, CADS is doing a great call. I'm excited about tomorrow's call on Monday, April the 6th. And I think that call is going to be quite informative. So with that, we'll call it a day. Thank you so much. Take care. Bye-bye.